it doesn't really, you can just, all you have to do is pull it back, and then I give it room to drop, okay? And he couldn't naturally drop it to enough, so you should do some stretches. Okay. Okay, yeah, sorry. The table is wrong. Okay.
Are you going to give me some exercise prescription after this?
Give you exercise prescriptions and massage. Good.
Right.
Good to go.
Gainsland's test. Okay, this one you do have to have him come towards me. Okay, lay down. Okay, now, what if I have a big patient? I don't want him falling off the table. I'll just have you come towards me a little bit more, just a little bit. I don't want him off the table. I need this to drop, have enough room it could drop. And then I'm going to have you bend your knee. Could you hug your knee to your chest, please? All right. And so he's pulling down and I'm pushing this way. It works best if I could do both. I have my knee, I'm holding him up, okay, and I'm pushing. And this is an SI joint test. Okay.
So you're just looking for any pain?
I'm looking for pain. Okay.
So you were pushing down on
I was pushing down. I was guarding the whole time. You don't want your patient to fall. Okay. You can't do all these tests on everybody. If I had a really big guy, I would be afraid I might drop the patient off the table. So I might not do this test on that person. Okay. All right, you can move more to the middle.
And then Trendelenburg.
Trendelenburg. Okay, the way Molly, remember there were a couple different things. For Trendelenburg, have the patients back towards you. Have them hold on to the table because if they really have a weak gluteus muscle, they could fall. And then have them just pick up one leg. I'm not holding myself on the table, but it's there, okay? And if I had a weak one, I would fall in. And then do the other side. And you should do both sides because you can compare. And you could do it the way Ken was saying, but it's not on the checklist.
The weak side is the side that goes up, though.
Yeah.
Your normal side is what drops.
Yeah, well, watch what happens. Okay, so if this, so I'm standing and it's like this, so it's like this. Well, yeah, I was helping it. You're right. I was doing what I shouldn't be doing.
It's the side that,
right.
that you're standing on
Right.
because it's not
Right.
strong enough to
Exactly.
account for that.
Right. If I was strong, I'd be level, and you're right. This is the higher side. Okay, and you can see with the waistband of the pants. That's a good indicator. So if the waistband doesn't stay level, that's a very good indicator. You probably wouldn't even have to think about it. If the patient starts doing weird things, like say ask them to just stand straight. Okay, and if they fall into it, then you should see this. And then this is not on the checklist, but Ken said to have them walk because you were looking for the Trendelenburg limb. It could be remember both sides or one side. Okay, if they had the weakness. Yeah.
There's really good videos of the Trendelenburg gait on YouTube.
Yeah.
Knees and legs. So
Okay.
inspect quads.
So you're inspecting everything, and with all of your range of motions for all the joints, have your hand on the joint for every joint. When you're doing passive range of motion, feel for crepitus. For every single joint you do, make sure you feel. Don't just move the joint around and have your hand somewhere else. You really should feel for crepitus, okay? For any joint you do, okay?
So knee alignment.
Knee alignment, so you have the patient stand up. You're looking for, see I've got a little bit of a varus, unless I turn totally. So you're looking for that. He's got a little bit too. So you have to have them standing.
Varus is bow-legged, valgus
Varus
is
is bow-legged, yeah. Valgus would be like this.
Valgus would be varus. Oh.
Yeah. Most of us
feet
tend to have a little varus. It's pretty.
Are we going to actually have to calculate the Q line?
No, you don't have to check. You don't have to measure the Q line. You have to explain how to do it.
Okay.
Okay. So you would. Okay. So you don't have to measure the Q line, but you have to explain how to do it. So you would explain that you would measure from the ASIS down towards the medial aspect of the. So it's actually, if you want to lay down, you can really see this. So I would say that I'd measure from his ASIS to his medial patella. So I'd measure this line, and then that goes beyond that, you know, like especially if you had an X-ray. And then I would measure from the inferior pole of the patella to the tibial tuberosity, and I'm measuring these two, and if the angle was very wide, greater than 30 degrees, I think they said, then you'd be worried about the patient having a patellofemoral syndrome. And again, remember it happens in wide-hipped females more often than anybody else. And then the other thing to check for is when you're checking for patellar mobility. So I want to get it to where he's relaxed. Okay, so he's relaxed right there. See how his patella is nice and mobile? Okay, I'm checking that. I'm checking for crepitus. This is what I added on your sheet is if you can, when you're moving it medially, check the underside. That's a nice check for if there's any arthritis or if they've got knee pain. That's a good habit to get into.
Tenderness of deep surface?
Yeah, the deep surface. Okay.
Your patella should go less laterally.
It goes less laterally. Yeah. If that's a natural thing, if you check your own kneecaps, it usually does that. Okay. Here's the tibial tuberosity is right here. His is not very prominent. If you have anybody with Osgood Schluter's, it's very prominent.
What about J-line tracking?
Okay, so the J-line tracking, if you want to sit up, and so you just have the patient sit at the end of the table and just have him extend his knee. We're looking for how his knee is going to move. He has none. If it J-line tracked, it would go up, and then at the very end, it would go whoosh and kind of go laterally, and it's like an upside down J.
So we would say that they have positive J-line tracking.
Right. And so I think somebody, did Mitra have a positive?
Oh, yeah.
Yeah.
Hers was
So
big
she's
time.
got a good one to look at.
So,
I'm surprised that we probably have more positives because it would be unusual to not. It might be a mild J-line, but a lot of women have a very mild where you could really see it. Trying to feel it like this. Okay.
palpation of the popliteal space joint.
Okay, the joint line is right here. When he's bent, the joint line is right here. And if you have any, you can move the knee around to feel it. And I'm feeling all along for if he has any pain or tenderness. And the posterior joint line was where Ken was saying most patients have their pain. And the popliteal fossa is the back of the knee. So you're feeling in there. We've already felt all around the kneecap.
And then the anserine bursa.
The anserine bursa. So on the skeleton, you could see it's painted in there for you. It's on the medial side of the tibia, just below the joint line. Right here is where the sartorius inserts, the gracilis, and the semitendinosus. Right in here, and there's a bursa right over those three tendons. So, and they're on the skeleton. Okay, right there.
Which muscles did you say?
Sartorius, gracilis, and semitendinosus.
That's invasive.
And then you do the passive range of motion. So flexion, extension, and then strength testing.
Okay, and strength testing you could do both together. Push out against me, pull back.
And then the special tests, so the ACL and PCL.
Okay, so the ACL, so if you want to get on the table again. All right, so ACL, so a couple different ways to do it. So bend your knee, okay, and so I could sit on his knee, and I could do the anterior drawer, the posterior drawer, and then to do the Lockmans, if you're shorter like me, so, and don't have big hands. So I'm gonna so my thigh right now is working like my other hand. If I had big enough hands, I wouldn't have to do this. So what I'm basically doing is now I could just lift up on his lower extremity, on the distal part of his lower extremity. If I could help it with my hand, I am. So this is pushing down and this is pushing up. He's not having any laxity. I could do it right there. He has hardly any laxity. Okay. And then the MCL and the LCL. The MCL, and I would recommend checking these bilaterally because you're trying to compare size. So the MCL is here. I'm going to put the force so that I try to open it like a book. So I'm opening it. I could bend and try it again. For my hands, it's harder, but it's okay. And then you can try it on the other side too.
So you're just doing a varus and a valgus stress.
That's all I'm doing. I'm actually doing a valgus stress for the MCL. I'm going to do a varus stress for the LCL.
And you do it at 0 and 30 degrees, or just? You
could do it. I think it's fine to just do it at whichever you can get some movement. You know, you got this big, a very muscular part of the body. I have to do it where I could get it moving the most. Yeah. So if you could picture the ligament, like if it was torn, it would open. Okay, so that's what I'm stressing. If this one was torn, it would open this way.
Okay.
So if you visualize it, you don't think about it too much.
So McMurray's test is
McMurray's test.
And this one is.
So this one you could do a couple different ways. I do it, let me try to do it on this side. Okay, so I bend his knee. I put my hands here. I'm going to internally rotate the distal part, okay? So I'm really grinding right now his menisci together, and then I'm gonna pull it out, and then I'm going to externally rotate, and I'm grinding on this side and pulling out, and then you could just repeat it a couple of times. And some people try to put a valgus and varus stress on at the same time.
You're feeling for clicking, popping?
Clicking, popping, or he says he has pain, or it locks. So that would be a
And
problem.
when you bend, you're moving the foot out and in?
Yeah, I was actually rotating.
Okay.
I was rotating the distal part in and out, because when I do that, it grinds the menisci together.
Right. Okay, thank you.
And Thessaly is standing, so do you want to do it with me? Sure. Okay. So we would hold hands, okay, and we would both do the same thing. I'm going to have you stand on one leg and bend, and I have you turn. I'm trying, if you bend your knee, can you bend it a little bit? It's harder. But you're trying to reproduce any pain with rotation. Okay, that was what we were trying to do. You're welcome.
You did want to dance?
And that one you do bilaterally, probably?
You could do it bilaterally. You're really checking the side that has pain.
So they need to bend their knee while they
It
do
helps
that.
if they can bend their knee, because you're trying to make the movement at the knee.
Okay. Now we're to ankles and feet.
Okay, so for ankles and feet, I don't know who wants to take off their shoes.
Joe, you're on the table.
Do you want to? If you don't want to, we can have
Down
someone
the
else do
end,
it.
you might as well finish it.
If you don't want to, somebody else.
This one, just like on the palpation, there's so much to palpate. I want to
There
make
is.
sure that
I do want to make sure you know where it
get in
is.
the right spots.
You could just leave one. Well, I only need one. Okay,
Feet
so,
counts now, but-
I don't care. So, okay, so first of all, let me show you the anterior drawer. I know that wasn't the first thing, but this, what I'm doing is I'm trying to shift the foot. If it were the relaxed ligaments, I'm actually, he doesn't have any movement at all, so you can't even tell what I'm doing. I'm pulling up on his heel, okay? Now, for all the points that you're palpating, okay, first of all, the Ottawa ankle rules, so you're palpating the medial malleolus, the lateral malleolus, but specifically you have to palpate the posterior sides. You might as well palpate the anterior sides, the posterior sides, and then the midfoot, and the naviculars in here, and then the base of the fifth metatarsal is here. Those were the Ottawa rules. Then the most common ligament to be torn in an ankle sprain is the anterior talofib. So fibular side, talus is in here, so it's right here. It's from the base of the fibula down to the talus. So right in here, if he tore this ligament, it would be very tender right here. It's the anterior part of the fibula. So that's the anterior talofib. The other place to palpate is the head of the fibula, which is up in here, right here. Because if he had a high ankle sprain that was so traumatic, it avulsed the top of his fibula, this is where he'd feel the pain. Okay, so right there. These two bones, the fibula and the tibia, are held together by an interosseous ligament, and that's called the syndesmosis. And so if he had torn it down here, which is called a high ankle sprain because it's above the actual ankle joint, that's where you're feeling. So this is the syndesmosis, right in here. It's right here, okay? Then the navicular was here, and the base of the fifth metatarsal was it's right here. It's that prominence on the lateral side. And then there was also squeezing of the metatarsals and palpating along them. There was the arch of the foot. This is the top. The bottom is the bottom of the arch. I think that's all. Is that all the palpating places?
Calcaneus,
Oh, the calcaneus is the heel.
Achilles tendon.
The Achilles tendon is back here. Okay, and then we have the special tests after that, right? Do we have
Metatarsal joint?
the metatarsal joints are here
Okay.
and right in here.
All right.
And these are the tarsal joints. Okay. And then the squeeze tests are, the Thompson is best if he was prone, but he's not prone. So I'm just gonna help you just relax, and I'm gonna squeeze, and then I can feel that he is plantar flexing. If his Achilles was torn, it wouldn't move. The best way to do it is prone and his feet hang off, and when you squeeze there, you're looking for this. You're looking for this movement. If it doesn't move at all, you're worried. Okay. The squeeze tests for the high ankle sprain, mid squeeze is here. If he tore it here, he would have pain because I'd be squeezing like the opposite ends of a tong and making the bottom of the bones go out, so the inferior ends. And then it's the same thing up here. It would really do that. At the same time, you're really pressing on the head of the fibula. So honestly, if there was pain here, I'd be careful about do the squeeze below it, because if you've got a fracture there, you don't want to be pressing on it. So I'd be careful of doing a high squeeze if you really thought there was a fracture up there. But that's the high squeeze, and this is the mid squeeze. They really test the same thing. And then, so, and your pain would be here. Pain would be where the tear is.